Well, hello there. How you doing? This is D, and welcome to episode 141 of the Benzo Free Podcast. Well, today we have a special surprise, and I'm really excited about this. We have a two-part interview with Dr. Alexis Ritvo. We've had her on the Benzo Free Podcast a couple of years ago. She is a colleague of mine. I've worked with her at the Benzodiazepine Action Work Group. I've worked with her on research teams, and I really wanted to get her back on the podcast, and she agreed. So I'm so happy to have her here. We did record this in two parts on two separate podcasts, which is exciting. The first half of this will be right here on the Benzo Free Podcast. And the second half will be on our Uneven podcast, the other podcast we have. It's easy to find each other. If you have any question as to where the Uneven podcast is, you can find it on most of your podcast carriers, just under Uneven Podcast. And if you're on YouTube, it's on the same channel. We post both our Benzo Free and our Uneven podcast on the same channel on our YouTube channel. And if it's somewhere else, and if you have any other questions, I have links in the show notes in the description. So just go down to the description and you will see links to the second half of this. We want to make it as easy as we can for you to find that. Of course, you can also find it at our other website at easinganxiety.com. All the episodes are listed right there on the homepage. A lot of easy ways to find the other episodes. So please, I hope you'll go check that out. And while you're over at the Uneven Podcast, I hope you will subscribe over there or join to follow it, because I think that's we're getting a lot of content going out there, including we're doing weekly podcasts there now every week on Thursdays from our Uneven community, which is at uneven.life. If you haven't been there, please check this out. But we do those weekly podcasts there at Uneven, and I hope you will come and start to listen to that podcast too. This one was recorded live in our community at uneven.life. So if you're part of that community, you also could have been part of this recording. We had several people online listening, and even some suggesting questions in the chat room, which we also asked Dr. Ritvo while she was there. So that's one of the perks of being part of our community, is you get to be part of these live podcast events and interviews and conversations and roundtables and all that exciting stuff. Gotta love that. I just gotta love that, don't you? I also do want to mention something really quickly here, that the Benzo Free Podcast is for informational purposes only and should never be considered medical advice. I always want to mention that here, especially when we have a physician on our show, that nothing said here should ever be considered medical advice. This is just a conversation between two colleagues, and I think it went really well. I think you're going to really enjoy this one. And I want to introduce you, tell you a little bit about Dr. Ritvo. I'm not going to waste a lot of your time on other things today, because this is all about that conversation. So let me tell you a little bit about Dr. Ritvo, and then we will jump right into the conversation already in progress. So yes, I do need to read this. So it is, if you see my eyes wandering off to the side, it's because I'm reading her bio, but I want to make sure I get this right. So Alexis Ritvo MD, MPH, is a board-certified addiction psychiatrist. She is the program director for the Addiction Psychiatry Fellowship at the University of Colorado School of Medicine, where she is an assistant professor of psychiatry. She earned her medical degree and a master's degree in public health and health policy from Emory University in 2012. She completed her general psychiatry residency and addiction psychiatry fellowship at CU before joining faculty in 2017. Since then, she has been a supervising attending of general psychiatry residents in the CU Medicine Outpatient Psychiatry Clinic, where she directs a co-occurring disorder subspecialty clinic. Her growing interest in the safe prescribing and deprescribing of prescription benzodiazepines led her to co-found the Benzodiazepine Action Work Group with the Colorado Consortium for Prescription Drug Abuse Prevention in late 2020. In 2022, she became medical director for the National Nonprofit Alliance for Benzodiazepine Best Practices. And she is the current chair of the Education Committee for the American Association of Addiction Psychiatry, and has a passion for psychotherapy, teaching trainees, improving health systems, and advocacy. And I stumbled over a little bit of that. I apologize, but since this is live, I'm leaving it in. But I think you got the idea. Anyway, Dr. Ritvo is one of my favorite people. I love having her on. I love working with her. She's been just amazing and so supportive. So before we, yeah, without further ado, that's what I'm trying to think of is without further ado. But anyway, we're going to jump right in. Oh, before I do though, I want to mention, did anybody notice anything different? If you've been listening to the podcast lately and have seen the podcast, I had tons of junk back here. So our studio is now cleaned out. So I got all the junk out behind us. It's the next step in building our studio. So this next step will be starting to paint some things, hang some drapes, start to get some furniture in here, and we are working on our studio. I just wanted to throw that out there in case you see behind me. And the color for the Benzo Free podcast is green, so I have green backlight. When we do second part of this, it's going to switch to blue because that's the color for the Uneven podcast. I'm not too fancy or a great designer or anything, but this is as advanced I get. I have some LED lights that I can change the color of, and they switch depending on what we're doing. Just thought I'd throw that out there. I hope you all are doing okay. I know I'm rambling on 1,000 miles an hour. I do that sometimes on the podcast. But I just wanted to welcome you all and thank you all for coming. And I hope you enjoy the conversation. Don't forget, this is only part one. Please check out part two after you listen. So without further ado, see, I got that in just right. Let's join the conversation already. What about you off job? Just kind of fill people in because, you got so many exciting things happening with you offsite. And I just wanted to check to see, kind of get people to get to know you and understand who you are a little better. You got 3 kids, including a new one, relatively new one.
I know
Thomas.
you've known him from the beginning, but
yes,
he's now 2 and 2 months and talking up a storm. So
yeah. So how are they doing?
overall good. I mean, they keep us very, very, very busy,
That's
and on
good.
our toes. So no way to learn child development like watching it unfold in front of you and learn that they're always throwing something new at you.
And you did, what was it? Last year, you did a cruise with an infant and 2 kids, so 3 kids. How did
Yeah.
that go for you?
I think all in all, it went
Yeah?
very well. I mean, there were moments in the middle of the night or otherwise where you wonder what choice you made. But some
Okay.
people refer to going on vacation with young kids as parenting in another location. But I think it's still nice to get out and see different things and see the
Yeah.
kids get to interact and view the world uh,
Um,
more than just what's around them on a daily basis. So.
Yeah, a little insight after her youngest one was born, Thomas. We would share pictures, and so she would send me all these pictures. 'Cause I kept asking for pictures of Thomas because it was just fun to watch him grow up. And so the only thing I had was Murphy, so I'd send her pictures of Murphy because we got him about the same time that you had
Mhm.
Thomas. I wanted to question. So you've been a psychiatrist for many years now. What brought you into psychiatry? What interested you in that occupation? I know you have family
Um,
history, but
yes.
was that the
So,
primary thing, or was there something else?
I mean, I think it started with, so I always get it if I'm number 10 or 11, if you look among my Ritvo lineage. So I was told it's either a calling or a disease, depending on your view of psychiatry. I mean, I think I saw both. So both my parents are psychiatrists. My grandfather is a child psychiatrist. My aunt and uncle are child psychiatrists. So I saw that my parents very much enjoyed and got great meaning from their work and their relationships with their patients and with their
Yeah.
colleagues. Um, and so I think that was probably the primary thing was that they seemed to be doing something that they enjoyed and got meaning from.
Okay.
Um, and then as I went through school and eventually to medical school, I think that was the same feeling as I wanted the opportunity that I could spend more time with my patients than often medicine
Mhm.
affords you. Um, and I knew I enjoyed teaching, so that was, I wanted an environment where I could also do a lot of supervising and teaching. So
Right.
it ended up being kind of a natural fit. And I was in medical school in Atlanta, but came back to Colorado, which is where I was born and raised and my family is.
Yeah.
Um, and so that is how I ended up back here and in psychiatry. So
Oh, that's good to know. That's good to know. All right, I'm going to go the benzo track here with us for a
Sure.
little bit, if that's okay. First of all, you and I have, of course, several things in common between research and, of course, some community groups. I know one of the first groups you got involved with, and I'm sure you had interest in benzos before that, but one of the first groups you got involved with was the Alliance.
Hmm.
What else did you do before that, and what brought you to the Alliance for Benzodiazepine Best Practices to eventually become their medical director?
Yeah, so Steve Wright, who was the
Okay.
medical
Yep.
director before me, and before he retired and moved to Oregon, lived in Colorado.
Yep.
Um, we got introduced, and I'm sure maybe you were on the same call, or you maybe were in person at
Probably.
the CDPHE meeting.
Yes, I was at.
I was on
Uh,
the phone call,
that's right. You
and
were on the phone. I was there in the room. Yeah. Okay.
yeah, and I think John State was there, and Jill Hunsaker.
Christy was on the
Um,
phone out of
yeah,
Dallas at the time. Yeah. So.
so. I think prior to that, I'd done my general residency training, I'd done specialty training in addiction psychiatry. Within addiction psychiatry, you develop a lot of, I guess, experience in thinking
Right.
about patients being physically dependent on medications and substances, as well as then obviously having the other components that are part of addiction, which would be,
Right.
loss of control of use and consequences from their use. But I did most of my clinical work in a general outpatient psychiatry setting. And so there I was mostly seeing people that were on benzodiazepines and more often than not came to us on them, usually long term, often from primary care where they were, most frequently started, but sometimes from other
Yeah.
psychiatrists, um, and then seeing how challenging it could be to try to reduce these medications and or
Yeah.
stop them, knowing that long term we were worried about risks that come with long term use, but that it was really challenging. So I think that was where my initial interest came,
Okay.
and I got connected with Steve Wright, who was the initial medical director at the Alliance, and he was already in the midst of, I mean, working with them, working on the textbook, The Benzodiazepine Crisis.
Yeah.
And then I think the group of us
Hmm.
within Colorado started working on the Benzodiazepine Action Work Group, which we then had folded into, or brought under the, I guess, umbrella of the Colorado Consortium for
Consortium.
Prescription Drug Abuse Prevention,
Oh, you
who
do
was,
better than I do on that. I can never say that whole thing without tripping
yeah,
over it every time I do that one.
yeah, I've practiced that one a few times. So
Did you?
I think
Okay.
that, yeah, and they were doing a lot of work or had been a lot of work at the state level around
Right.
opioids, opioid prescribing, chronic pain, and opioid use disorder. So that
Okay.
was kind of how my initial interest in um, benzodiazepine prescriptions and physiologic dependence and trying to help patients more um, safely and comfortably taper off
Right.
benzodiazepines
Oh, great.
developed.
Oh, that's good. Yeah, I know you've been working with them for some time, and then when we part of that work that you did there, of course, migrated into creating the Benzodiazepine Action Work Group, as we mentioned. And you were originally co-chair along with Dr. Stephen Wright, and he stayed on for a few months, but he was so near
Hmm.
retirement, he didn't want to stay too long. And then I popped in after he did. And one of the things that he really wanted, which I appreciate, was he wanted it to be one medical professional and one lived experience person, that co-chair that work group. And I thought I really appreciated that. And so I took that role on, and you and I worked on that for 3 years. And
Yep.
then both had chats after about year two. You and I both had this conversation going. So when do you think you're going to step down, and when do you think you're going to step down? Because we knew it was coming. But you and I both stepped down earlier this year
Hmm.
from that role. And I just want to look back at BAWG and your experience with that. This is a benzodiazepine action work group for those people that don't know. As she mentioned, it was under the umbrella of the Colorado Consortium for Prescription Drug Abuse. See, I told you I can't do it.
Hmm.
I can't do it. Prescription Drug Abuse Prevention. And right now that is being not dissolved, but it's being transformed. That group is now being pushed, is being distributed, the work they're doing into other subgroups within the group.
Hmm.
And so since it's kind of coming to a close, a little bit of some of the work we've done there, what do you think are the accomplishments? What have we accomplished and what was done from there? And what do you think about the transition and the future of it?
Yeah.
Just your thoughts on it.
I think we had a lot of accomplishments. I mean, first, we helped, I think you and I forget who else testified at the
Yeah.
state legislature
Yep.
virtually because this was during the pandemic, to ensure that some regulations got put into law, um, trying to limit initial prescribing of benzodiazepines. So
Yep.
that was a big accomplishment. That now in the state of Colorado, if someone has not been prescribed a benzodiazepine in the last 12 months, then
Yep.
they initially must be prescribed a limited quantity. It got determined at the rulemaking level, how much that was, and they decided 30 days. I would have preferred to see 14 days,
Yeah.
but at least it's there. And in some of the health systems, like where I work, our medical record system, if it detects that someone maybe has not had a benzodiazepine in the last 12 months and you're trying to prescribe more than 30 days worth, it will
Hmm.
actually give you an alert. So the hope was that, like we saw with opioids, that if we can initially try to limit people being started on long-term
Yep.
scripts, then we can ensure that they get better informed consent about the benefits and risks of these medications, short and long term.
And that's one of
So
the
it,
things I think to emphasize with people is that was the nice thing was we were avoiding what we didn't want to fall into was the inaccessibility of medication for deprescribing, for people coming
yeah,
off them. And this rule actually let people that were already on long term stay on them so they can figure out their own taper course or whatever they is.
right.
It's
And it
only the
didn't say that
new,
had to.
yeah,
hmm
right.
it didn't matter if it was the same prescriber or not because people
Exactly.
transfer prescribers. It was really just to try to limit the people that hadn't been on these medications regularly,
Yep.
were given more of a brief script and to ensure that there was
Right.
conversation and follow up about what happens next.
Yeah. I love that.
So
I love that. Yeah.
I think that was a huge one. As part of that law, there was also um, an increased requirement about education for medical professionals. So there was already some education requirement around substance use disorders, and they added to that benzodiazepines could be one of the topic that
Yep.
providers take education, continuing education on, and provided funding for us to do what ended up being 4 hours of didactics that got continuing education
Hmm.
approval. You did some of them. I did
Yeah.
some of
And
them.
we got another one coming up too. When's the lunch and learn? February?
Yeah, February
Yep.
12th.
Okay. Yep.
And so we had, four recordings. Or I guess initially we gave them live, then they went back and recorded them and posted them as free continuing education that anyone can access. It was
Yep.
specifically geared towards Colorado providers, as that's where the funding initiative came
Yeah.
from. So I think that was also a very big accomplishment. I think another thing which Steve Wright had largely um, driven before he stepped away more, or he at least started, was creating the prescribing and deprescribing guidances
Yep.
that we posted on BAWG's website. And then
Good.
I know you were very involved too in the peer support
Yeah, I
guidance.
worked
So
on
I
the peer
think
support one. Yeah.
having these brief but very comprehensive guidances that individuals and prescribers could refer
Hmm.
to get some more guidance on how to approach safer prescribing, how to approach
Yep.
safer deprescribing, how to provide better support to individuals um, on these medications and undergoing
Yeah.
tapering. I think all of those were very substantial. I mean, I know that even the deprescribing guidance then helped inform the Maudsley deprescribing textbook that people that had worked on that then were also working
Right.
on that. I didn't have any part in the Maudsley, but some of our other colleagues. So I think all of that, you know, were pretty substantial
Okay.
efforts. And then, of course, I was much less involved in the peer support curriculum. Um,
Well, you were in charge of the
and
CME. That was you had plenty of
yeah.
work with that one. I worked on the
But
peer
on
side. Yeah.
but on the periphery I was, and of course that was a huge accomplishment because really nothing like that
Yeah.
existed before, right? Is peer support curriculum with
Yeah.
specific focus on this topic.
Yeah, and that was thanks to a huge team. I mean, amazing people. We had 12, 15 people working on that, all
Mhm.
organizers from within the benzo community. So it was a team effort for sure.
Yeah,
Yeah.
absolutely.
Yeah, that's great. Fill me in a little bit too, since we kind of went around it, but I want to jump back to it on the Alliance. What currently is going on? You want to update me with anything that's happening in the Alliance right now? I
Yeah,
know you and
so
I are on research, and we'll jump into research in a minute, but let's talk
sure.
about other things the Alliances might be working on right now.
Yeah, so we have a con or subcontracted with Kaiser in Washington on a contract they have called the Safe Use Initiative with the FDA.
That's great.
So that project, Kaiser is doing an intervention within the medical record system to try
Mm,
to help support prescribers as they're looking at people that have been on benzodiazepines long term and how to approach engaging them in the conversation about
yeah.
tapering and to see what is most useful in helping support prescribers and making sure they're having those conversations and have the tools and information they need. As part of that, the Alliance was contracted to provide provider education
Okay.
around safer prescribing of benzodiazepines. So we had to go through a very rigorous process of creating two presentations where we provided the level of evidence for um, every citation we were using, anything that we were saying, we had to say this is where the information came from and this is the type of study it was. Um, and then the FDA and Kaiser, reviewed all of it and provided
Yeah.
feedback on all of it, and then created a kind of final version of it. And a few weeks ago, I recorded it. Um, haven't seen yet what the recording looks like, so hopefully it's okay. And then that will be utilized by Kaiser to provide to their prescribers. And then I believe my understanding is that the line still will have access to it, and then can also
Okay.
use that, not both the material and the
That's
recording,
great. That's great.
um, as further
Okay.
education for providers. So that's been one of the very big projects. They're continuing to look for opportunities similar to you and other people working in the space for just as much, education and involvement as possible. Um,
Gotcha.
whether that's through, being interviewed for articles or just
Yeah.
as opportunities come
Yeah, there's
up.
some of those floating around right now. Yeah, that is in the
Hmm.
process. So yeah. Um, okay, let's jump over to. I know research is a question a lot of people have, and you and I were both part of the benzodiazepine research team that's been sponsored by the Alliance over the past,
Hmm.
3 years now plus or whatever.
Yeah, more
Um,
than that, because it
I
was in
know.
existence before I joined.
Well, no, yeah, when Christy and
Jane.
Jane, thank you, Jane McCoubry, yeah, initiated the survey, and
Hmm.
then I know I got pulled in to work with Jane on the data. And you were over on the Bernie side, kind of working that angle, and we all kind of accumulated and started on that first paper. So,
Yeah,
yeah,
I didn't join till the
that's
third
right. You wanted
paper.
the
So
first paper. That's
I
right.
no, you achieved
I
two
can't
before I
keep
even
track. I
got
can't
pulled
keep track.
pulled in.
Yeah.
So
But anyway, so the nice thing is that survey of 2018, 2019, the benzodiazepine survey led to really up to that third paper, the one that you were the lead author on. And it was the one that introduced bind. And I know that's been a topic because it's all over the place. It's really spreading. I know in the benzo community, I do hear of it constantly. People mention it to us. And we're teaching different courses on it. I'm getting ready to teach a course on bind coming up on Uneven that we're going to launch here in a couple months. And it's a real good topic. But I'm kind of curious about some of the science and the medical side of it behind it because we get a lot
mhm.
of questions. And this is what I want to ask you. I'm more the data guy on that and kind of some lived experience, but, I have to look to you and Dr. Martin
Mhm.
and Dr. Finlayson to kind of get the background on the medical side. One of the things I get a lot of times is the crossover. It's like I think a lot of people think that, traditionally people thought this protracted state didn't start until like 18 months after. Because that's what some of these,
Yeah.
Ashton mentioned that, some other places I mentioned in my book. So I'm guilty of probably adding to that whole thing. But we thought, well, until 18 months, that might be normal withdrawal, and then it might be. But when we started looking at this and started working, we realized acute is probably just that first 30 days. And then after that, it might be more bind. And then people ask, well, what about tolerance? Can you get bind? And I know Bernie's been working on the timeline, and we realized how complicated doing a timeline of when bind kicks in really is. can you shine some light on this discussion? Because I've tried to, but it's a difficult one. People
Yeah.
want to know, like, when can bind kick in? When can you have a symptom of bind? And I try to tell them it's not linear, but it's hard to explain that. You know what I mean?
Yeah. Yeah. I mean, a lot of it is right. We just don't have enough good research to tease it apart. I frequently refer to, looking at what we know now about long COVID, right? That
Yeah.
I mean, with long COVID, you at least you have this large group of people, unfortunately, affected
Hmm.
at the same time that has driven being able to gather a lot of data
Right.
and a lot of information and trying to understand it. And I think, like most things, we come away with knowing it's very complicated. And I think we
Yes.
know with buying, that's the same thing, right? We know there are certain risk factors that make people at higher risk for developing bind. The higher dose you've been on, the longer you've been on it, the more times you've kind of abruptly stopped or greatly reduced, having more medical comorbidities, having more psychiatric comorbidities, being on more other medications, all
Yep.
would increase your risk. And yet we also know people that have none or very few of those, and just being on these medications, even what are considered lower dose,
Right.
although often potent, so more than we think, and shorter duration, they end up with bind. And so, we still don't know the exactly, okay, why are some people so much more sensitive to this?
Yeah.
Um, and then I think there's the issue of, yeah, you have two, you have a bunch of overlapping mechanisms at play, and that are all contributing to this, and also contributing to why it presents so differently in different people as well as differently in someone at different times. So I think you have, acute withdrawal, which really happens as the medication's leaving someone's system.
Hmm.
um,
Right.
but
Exactly.
I
Which is
also
usually
think,
about, yeah, what, a few to 28 days or whatever. That's the window
yeah,
that
it depends
typically
a little
happens.
bit on, yeah,
Okay.
which medication, right? The longer acting ones,
Right.
especially in someone that's older, if it's one of the hepatic or liver metabolized ones like Valium, could be 28 days, and the shorter acting ones, it's going to be
Yep.
more on the order of, 5 to 7 days. But then we also know that as your body is chronically exposed to these medications, you have all these adaptations that happen.
Hmm.
That is part of what develops tolerance in some people, also what puts people at risk for worse withdrawal, but I think also puts them at risk for um,
Yep.
for bind. So, we know there's the uncoupling for some people of how effectively the benzo pulls GABA to the receptor. And that probably for some
Yeah.
people might exacerbate bind. So these kind of neuroadaptations.
Yeah.
We also know that you get downregulation of your GABA
Hmm.
receptors when you're more chronically exposed to benzodiazepines, because your body is trying to just create a homeostasis. And so I think, as far as we can tell, all of those things not only would increase your risk of acute withdrawal, but may also make, right, because it's going to take more time for some
Right.
of those neuroadaptations to reverse or hopefully heal. And then there's this third idea that I know our colleague Dr. Peter Martin talks about a lot, of neurotoxicity, which
Yep.
again, there's me, I don't know the literature as well, but I know we've talked about, I know there's some studies that have looked more at the kind of cellular level, or in rodent models, what
Hmm.
happens with chronic exposure to benzodiazepines, and that at some level, there's parts of it that are toxic to your nervous
Right.
system, and whether or not with time, which it does seem overall that time is healing,
Hmm.
uh, but with ups and downs for different people, for again, because there's all these other complexities at play, but that overall with time, some of that toxicity probably, reverses or goes away.
Yeah.
But there may be some parts or damage that is permanent, and
Okay.
we just don't know. I mean, unfortunately,
Exactly.
it's a super
That's
complex
the
thing,
fun part. Yeah.
and why I mentioned long COVID is my hope that something that is so multi-systemic, that has such significant impacts on someone's functioning, that as they figure out how to look at that complex
Yeah.
disorder, that it will give us more ideas of how to approach something like bind. And then, of course, we need to find the people that have the funding and the expertise to
Yeah,
then
there's a lot of
pursue
layers to this,
studying
isn't
it.
there? I know,
Yeah.
to getting the research done. Yeah,
Hmm.
but we are making so much progress, and I think that's what's pretty amazing. I remember Dr. Wright, Steve mentioned back in one of the conversations about not just because we focus so much on GABA A, we focus so much on the receptors, the downregulation, and everything. But of course, he also went into peripheral. He went into mitochondria. What is he referring to? What does he mean by that? And how is that
Oof.
different? What does that affect? Do you know much about that side of it?
Yeah, I know his mention of it, and I have to
Yeah.
be honest in that I have not looked into that as
Okay.
much. I feel like so much more of my regular focus is still trying to uh, doing a lot of deprescribing
I know.
and a
Yeah.
lot of educating.
Yeah.
So, but yes, I think the big point is it's not even just at the receptor level, right? This is at the
Okay.
like minute cellular level
Right. Right.
that there's changes going on, and we know things like in mitochondria. I mean that it's very variable across individuals.
Yep.
Um, how those cellular levels are affected, but I would have to do a lot of rereading and educating before I could speak at all
No,
eloquently about
no,
that.
it's yeah. I know. I'm yeah. I'm of course starting from scratch with no medical education, trying to figure this out. But it's so hard to follow up and figure out all the different variables that can be at play that
Hmm.
factor into not only just what is actually causing this, but how each one of us differs in our response to it. Because we don't even know the genetic component, we don't know environmental components, we don't really know many
Yeah.
components as far as, and we know they have to have an influence, but we can barely, we're just now realizing this exists and actually proving it, in literature. Now we have to start
Hmm.
figure out, okay, well, who deals with it more severely? Why is that the case?
Yeah.
How can we avoid
And
it?
trying to identify what are the other, again, when we don't have uh, a good scientific uh, mechanism to
Yeah.
clearly explain it. What are the other things at play? I mean, I'm thinking of um, a patient I worked with recently who was having horrific akathisia, horrific, and
Actually, that's
I
something I
think
wanted to ask you about. So that's a great
yeah,
topic. Okay.
um, mostly is like, well, here are the things that for medication-induced akathisia are sometimes tried and recommended, but I also know that your system
Yeah,
is
it's a good question. What do
sensitive.
you say to somebody like that? What do you say somebody with severe akathisia, 24/7 akathisia, where
Yeah,
that's all they have is just this constant, overwhelming
yeah.
energy running through them?
I
How
mean,
do you treat that
usually,
as a psychiatrist?
yeah. There's the medications you can trial, but I have to caveat it with I know your system's super sensitive right now, and we
Yeah,
risk that offering you another medication that
right.
your body will also develop a dependence of sorts on, right? Whether that's
Hmm.
propranolol or mirtazapine, those are kind of the two most commonly used ones, aside from
Are they
benzodiazepines,
are they
right? Those
both
are
betas? Or I know the first one's a beta blocker. Is that okay?
propranolol is a beta blocker. Mirtazapine's an atypical antidepressant. It has a lot of
Okay, gotcha.
alpha adrenergic activity. Um, and so, I mean, we both know people. I mean, I've known people that have
Yeah,
had
I know.
difficulty with
Yeah.
both those medications. I've also known
Yes.
people that have found them helpful, right? So, telling them that in the absence of this, this would be usually if someone came in saying, I'm having akathisia, what we might try. But I unfortunately don't have the crystal ball to say this will be helpful, this won't help at all, versus this might make you feel worse.
Right.
I've usually, or increasingly, I would say, focused on looking at their overall nutrition, trying to figure out, because not infrequently, as people are not feeling well, right, it becomes harder to eat. It also becomes
Yep.
harder to make sure you're getting like full array
Well, and
of
anything can be a trigger at
nutrition.
that point. Anything can be. And diet, I know. For me, I had the
Yeah,
periodic akathisia, and I'm familiar with that. But thankfully, mine was not 24/7 or this severe, but it was
yeah,
periodic. But I did notice sugar definitely was, instigator. If I had sugar in the evening, then when I'm trying to relax with my wife, I had to get up and I would go exercise or play the drum set or something because my body just would not let me sit
yeah,
still. I had to do something. But if I didn't, if I ate a little more reasonably, I didn't have that as often. There,
yeah.
but it's a detective game you have to play.
Yeah. Yeah, in this case, the individual had both been on some chronic antibiotics for,
Yeah.
another issue, and then also had started really limiting their diet out of concern that
Yeah.
they were more
Sure.
sensitive. But I actually think it in part went the other way, where
Okay.
it became hard to maintain their weight. So we
Okay.
really focused on trying to get their
Still
weight
get the
back up
nutrition. Yeah.
and make sure they were getting kind of full nutrition. I think a combination of that and um, uh, time made a difference. We didn't, do any other things. So I will offer hope that, and a lot of it was just being a witness both to their discomfort and suffering, but
Yeah.
maintaining hope that with time this would get better.
And that's a lot what we
Um,
do. Yeah. That's what I do most of the
yeah.
time is trying to maintain hope and trying to keep people moving forward and realizing.
Yeah. And so making sure there wasn't, anything else we hadn't thought of or that hadn't been
Yeah.
looked at, but yeah, connecting with a therapist and
Yeah.
a dietitian, I think were probably two of the most helpful
Okay. Well,
things.
yeah, speaking of that, in some of the more severe cases like that, so say somebody, I mean, polydrugging, I know it's not the official term, it's just the term I know we use in the community a lot, but you know it. But with that, like say you're on an antidepressant and a benzo, do you have a standard protocol or does it depend on the person as to if the person wanted to taper, how do you start or which one you start with, or how do you factor
Yeah.
that in? Like, how do you decide which one to begin that process? If that's what again, I know you don't force anybody, we don't force anybody, but if they choose to taper off a
Yeah.
medication, how do you how do you help them make that decision?
Some of it is trying to see what the issues that they think might be connected to the
Okay.
medications they're having. Some of it is really trying to assess what the underlying or pre-existing reasons that both medications were started, as well.
Hmm.
I mean, I've had individuals that, and everyone's so unique, right, in their
Yeah.
experience, and you can't say that being or not being on the medication is absolutely, necessary or not necessary in one way or another. It's trying to do
Right.
their best to help come up with a, risk benefit discussion to the best of your ability. But I've had patients with history of horrific trauma, where we felt like trying to get them off the antidepressant,
Hmm.
um, while they would at this point likely be more challenging and make it hard to get off the benzodiazepine. And if the
Yeah.
issues are things like memory, cognition, risk of falls, that the long term, the benzo carries greater risk for them, again, depending on what their experience has been on the antidepressant. And so in that case, maybe just focusing on the benzodiazepine. But I've had other people that feel like they think that they're tolerating the benzodiazepine they're on right now okay, and that it's
Right.
more related. I mean, unfortunately, it is a lot of right kind of guesswork and just supporting them and trying. I mean, I think the big thing is I say, let's only make one change at a time. Let's try to do as
Yeah,
small a
makes sense.
change
Well, and also
as
you don't
possible.
know the effects if you try to do multiple ones. You don't know which one's causing the
Yeah,
problem then, and you wind up in a
right. And
conundrum.
that we'd be, yeah, and really trying to be like, would be better to do a small change and
Yes.
wait, or if we've got a lot going on, not make a change,
Okay.
then have, I think people can understandably, out of a lot of distress, start um, making
Okay.
changes really frequently. And then I start to worry that we don't know, kind of chicken or egg, how much of this
Yeah.
is what was pre-existing versus now that we're changing things up
Okay.
too rapidly on their system. So
I had one of the people asking beforehand on a question because it fits what we're talking about right now, but on taper plan. I know we had the Ashton manual with the benzodiazepine side. Now we have Maudsley. We have some other ones. I know Horowitz and them worked on that one. What do you recommend? Like if somebody's looking for a taper plan or a safe way to taper, what are like your key 3 points of advice you give people if they're looking at tapering, like how to go about
hmm
it, and what reference they should use or whatever.
yeah, I mean, I I am a big fan of Maudsley
Okay.
as like just a general approach, because I do think it makes it breaks it down pretty clearly into steps. I think for a lot of people, I mean, understandably, you still will need and want hopefully the support of a prescriber and or at least someone like a taper coach. Um, so I think that works well. I mean, my usual advice is make as small a decrease initially as you can, just
Yeah.
to kind of test the waters to see how sensitive you are to the process, knowing that it may change
Mhm.
along the way. Um, And so I think that would be the first one. Um, I mean, I've seen it go, I've worked with people along the entire spectrum of folks that either aren't able because of cognition or resources to do more of a smaller micro taper. And so we have to work with, what the medication comes in, or who's able to help support them in setting up a pill box. I've also worked with people who are like, I find it too overwhelming to try to
Yeah.
be to try to quarter this pill,
Yeah,
and
I was curious about
and so
that.
I'd rather half the pill and wait longer. So
Okay.
ultimately, right, the patient's in the driver's seat, and I'm here to support them. And so just talking through the pluses and
Yeah, do you,
minuses.
it's a good question. Do you ever get people that, and this has come up recently on our site at Uneven, lately is, I do wonder sometimes if the obsessive nature of microdosing, of really trying to get things, is that causing sometimes more problems maybe than the actual cut and getting it just right with some
Yeah,
individuals?
right.
Have you seen
It's
that or?
Yeah, I mean,
Yeah,
there's no way to know exactly,
I
right?
know, I
Some
know.
people's systems are so sensitive. And we know that our brains and our bodies are so intimately tied. But
Right.
I certainly think that, I mean, I know plenty of people who said, they knew themselves well enough or in a way to
Yeah.
say, I'm not going to, like, I either don't have the energy or don't, like, I will not go well if I try to do this too drawn out or too small of, and I need to just go a little faster and then
Yep.
and manage. Um, you know, yeah, unfortunately, there's not a clearer way for us to say, oh, this is physiologic only, you're
We
versus
don't know. We don't
psychologic.
know.
They're
Yeah.
all together, and your brain is part of your
Yeah.
physiology.
It's
Um, so I think it's hard. I think what can happen, I mean, just like we see when people are having difficulty with sleep or other things, is you do end up in this state, which is it, where you're constantly scanning, right? You're scanning your
yeah.
body and how you're feeling constantly to try to assess, do I feel differently than I did on that previous dose, and is it tolerable or not tolerable, and
Yeah.
can I function enough or not function, and so I think that's, I mean, it's just a horrible place for anyone to have to
It
be,
is.
and
Yeah.
trying to figure out how to the best of your ability to
Right.
keep doing what you need and to do, and hopefully do some of the things you want to do, and that's different for um, everyone. I think I've just seen that, yeah, I've had enough patients, again, either because of, I mean, all levels of education, all levels of socioeconomic status, and even age, where there's been a variety, a very, so
Yep.
we, or quite a spread of them saying, even though the Maudsley would say I should go down by this much, like, I don't want to do more than half the pill. And
Yeah.
so usually I'll say, okay, and just know we may have to wait a little longer for you to adjust to that dose.
That makes sense.
Or you might want to wait till particular stressors are not around you before you
Yep.
make the adjustment, depending on how sensitive they seem to be to the dose drops.
Yeah.
Um,
Thankfully, it's not overwhelming at all. That's the nice thing about
no, not at all.
it. I know it's so hard. It's so hard, and I remember being there as a lived experience person, somewhat, but I'm definitely exposed to it every day with the people we work with, and it's always such a difficult thing. Um, I got several questions here, but I am going to switch gears because
Sure.
I mentioned to you I'm going to do a two-part conversation here with Dr.
Okay.
Ritvo. So for those who are listening, this is the end of the benzo-free part. It doesn't mean we won't talk some benzo in the next section. And don't worry, I saw your chats, people who typed in advance and typed in during, and we're going to hit more of those up in this second section. But just give us about a minute. We're going to switch gears. I'm going to change the color of my background. See, I can do
Most
that.
importantly.
Yes,
Yeah.
that's the most important thing. And then we're going to kick off the uneven part, and this will be released both as an episode of Benzo Free, and then the second part as as an episode of the Uneven podcast. So we hit both podcasts. So, and that closes out part one of this podcast episode. I want to send out a special thanks to Dr. Alexis Ritvo for taking the time to speak with us today. I really appreciate her time, and also to remind you, this is only part one. We have a big section and a whole nother section called part two, which we recorded, and it's over at the Uneven podcast. Check out a link in our show notes Search for Uneven Podcast. You'll find it on most of the carriers, or see it on our YouTube channel. It's on the same YouTube channel as this one, so it'll be right there. You can also find it on our website at easinganxiety.com. On that homepage, it lists all our podcasts, so easy to find it. Please go check it out and listen to this part 2 of this conversation at Uneven. And that's going to be, I think, all we have for the day. I'm not going to waste more of your time, except to say thanks for checking this out. I really appreciate it. And I'm really happy you are here and listening to Dr. Ritvo, to myself a little bit, and just to seeking information, looking for solutions, looking for comfort, looking for hope. Keep doing that, and we all get through this. So hang in there. We got this. We'll figure it out. And now, as we close out, here's my disclaimer. Enjoy. Hey, this is Dee. Thank you so much for stopping by and checking out our podcast. I do need to remind everyone that this podcast is for informational purposes only and should never be considered medical, psychological, or professional health advice of any kind. You can read our full disclaimer on our website at easinganxiety.com/disclaimer. Also, if you or someone you know is dealing with significant mental health issues, please seek professional help. Resources can be found in our show notes and on our website at easinganxiety.com. Thanks again for stopping by, and remember, keep calm, taper slowly, and take care of yourself. I'll see you next time.